Welcome, curious minds, to the deep dive. Today, we're taking a shortcut to being, well, incredibly well informed on a topic that touches millions globally. We're diving into the complex world of hypertension, yeah, that's high blood pressure, and uncovering how our understanding of it has just dramatically shifted over the last century or so. We've got a really illuminating stack of sources today. It's centered around a powerful 2024 review called Clinical Trials in Hypertension, a mathematical endorsement for diagnosis and treatment. That's by Drs. Flavio D. Fuchs, Sandra C. Fuchs, Otavio Berwanger, and Paul K. Welton. So our mission for you today is to pull out the most important insights from these materials, maybe challenge some common assumptions you might have about high blood pressure, and reveal a really surprising pattern, they call it a mathematical concordance, that makes a, frankly, a compelling case for a revolutionary new approach to managing it.
Indeed. We'll journey from, these historical debates that once really clouded our understanding,
Yeah.
right through the rigorous evidence of modern clinical trials. And we'll connect the dots on precisely why this knowledge matters so profoundly for public health and for you, our listener. What's fascinating here, I think, is how the precision of mathematics has helped us truly unravel such a complex biological thing.
So the question is, how did we get here? I mean, how did we move from some, frankly, pretty radical ideas about blood pressure to our current understanding to really grasp the significance of today's science? I think we first need to rewind. Let's go back to the early 20th century and explore what the prevailing wisdom about high blood pressure actually was.
Well, in those early days, there was maybe a glimmer of recognition, but certainly no consensus, not at all. As early as 1913, there was Janeway's study, looked at nearly 8,000 patients, and it hinted that a systolic blood pressure, SBP, above 160 millimeter Hg might be a health hazard, mostly linked to circulatory diseases. It was a crucial first step, definitely, identifying a correlation at least between high BP and bad outcomes.
Okay, but despite that early data, it sounds like Janeway's findings weren't just immediately accepted. Like, what were the counter arguments back then? Why wasn't this link obvious?
Yeah, you're absolutely right to question that. By the 1930s, the role of high blood pressure as a cardiovascular disease, or CVD, risk predictor, it was still deeply controversial, really debated. And here's where the story takes a really interesting turn. A prominent physician, Paul Dudley White, in his 1937 book, Heart Disease, he actually argued that elevated BP was, get this, a physiological compensatory mechanism.
Wait, compensatory?
Yeah. His view was that the body was doing something helpful, maybe trying to improve circulation or something like that,
Yeah.
and interfering with it. Well, that would be detrimental.
A compensatory mechanism. So he thought it was helping the body, not harming it.
Yeah.
Wow, that's just starkly different from everything we're taught today. It really challenges our basic assumptions.
Exactly. And this viewpoint really highlights the contrasting scientific opinions of the era and the real struggle, to establish actual causality from just observation. However, just 2 years later, in 1939, a cohort study by Keith, Wagner, and Barker provided some pretty compelling counter-evidence. They showed a strong relationship between high blood pressure and subsequent multi-organ vascular complications, so kidneys, eyes, brain. This directly challenged White's view, and it marked a significant shift towards recognizing its harmful effects. It sort of laid the groundwork for more rigorous investigation later on.
Okay, so we had these initial observations, then these really conflicting opinions, and finally, some stronger observational data hinting at harm. But how did the medical community actually establish a causal link? How did they prove that treating high blood pressure really made a difference? Because observational studies, like you said, they can only show associations, right? Not definitive cause and effect.
That's right. And this is such a fundamental question in medical science, isn't it? How do we move beyond just seeing two things happen together to proving one causes the other? Observational studies, they can only highlight these correlations. They can't definitively say factor A causes outcome B because of what we call confounding factors.
Confounding factors.
Yeah, think of it like this. If we observe that people who carry umbrellas are less likely to get wet, does carrying an umbrella stop the rain?
No, of course not.
Right, it's because they carry an umbrella when it's already raining. The rain is the confounding factor. These hidden variables can really mislead our conclusions if we're not careful.
Okay, yeah, that umbrella analogy makes it crystal clear. So what was the scientific breakthrough then? What allowed us to move beyond those potentially misleading associations and truly understand the impact?
Well, that was the advent of randomized controlled trials, RCTs. The 1948 streptomycin treatment of pulmonary tuberculosis trial.
Yeah.
That's often seen as a milestone. It really moved experimental methods from the lab into the clinical world. It was a truly revolutionary approach to medical research because of its core principle. concealed randomization.
Concealed randomization, okay. And how does that provide the crucial causal link that the earlier studies were missing? What makes RCTs the gold standard, you mentioned?
So RCTs are the gold standard because by randomly assigning participants completely at random to either a treatment group or a control group, researchers minimize bias, and they effectively control for both known and unknown confounding factors, all those other things that might influence the outcome. This mathematical process basically ensures that, on average, the groups are balanced in every way except for the intervention being tested.
Ah, I see.
So any significant difference in outcomes we see, well, we can be much more confident attributing it to the treatment itself. That's where the mathematical rigor gives us those definitive answers.
Right. So when did RCT specifically start to impact hypertension treatment? When did they prove that lowering blood pressure actually works and it isn't just an association?
The first RCT to show a really dramatic beneficial effect of antihypertensive therapy, specifically for preventing cardiac and other complications. That was published in 1966 by Wolf and Lindemann. Then you had landmark reports in 1967 and 1970 from the Veterans Administration Cooperative Study Group on antihypertensive agents. These demonstrated the remarkable efficacy of a specific three-medication combination, hydrochlorothiazide, reserpine, and hydralazine, in preventing CVD in patients with certain diastolic blood pressure levels. These are really foundational studies. They truly showed the power of treatment.
Okay, so it's one thing to have the data, right? But it's another for it to actually change how doctors treat patients day to day. Did these findings have a quick impact on clinical practice?
Oh, absolutely. I mean, it's actually quite rare in medicine for data to cause such an immediate and profound shift. Look at the 1988 ISIS-2 trial, for example. That wasn't hypertension, it was heart attacks, but it showed low-dose aspirin and thrombolytic agents cut mortality by 40%.
40%, wow.
Yeah, and that led to a rapid, widespread change in clinical practice almost overnight. It just shows how compelling mathematical evidence from robust RCTs can fundamentally reshape patient care. It's the power of having that clear, undeniable causal link, something observational study just couldn't provide with the same certainty.
So with RCTs now firmly established, this mountain of data pouring in, what did all this collective evidence finally reveal about the precise relationship between blood pressure and cardiovascular disease? This cumulative understanding, I guess, is what eventually led to what our 2024 review calls this mathematical concordance. What is that exactly?
Right, this brings us to the core concept of mathematical concordance.
Mm-hmm.
And it is a surprising, I'd say profound pattern that's revealed when you look at all these materials together. Meta-analyses, which are, like taking hundreds of individual research snapshots and weaving them into one giant, incredibly clear panoramic picture.
Yeah.
Well, meta-analyses of antihypertensive RCTs show a near-exact reversal of the CVD risks that were identified way back in those observational cohort studies.
A near exact reversal.
Yeah, it's almost like looking at a mirror image, but for risk.
Can you give us a concrete example? I mean, that sounds incredibly powerful, almost too perfect. How does that alignment actually look in the numbers?
Okay, imagine finding a puzzle piece,
Yeah.
right, and then finding the missing piece, and it fits perfectly, not just in shape, but in impact. So observational studies consistently show that for every 10 millimeter Hg higher level of blood pressure, there was roughly a 25% increased risk of cardiovascular disease.
Oh.
But here's the truly astonishing part. When we lower blood pressure with treatment in RCTs, the meta-analyses documented a corresponding reversal of that risk by about 17% to 22%.
Wow.
It's like a scientific bullseye. It validates our understanding in a way that very few other medical interventions can claim. It's mathematically elegant, almost.
That alignment is truly remarkable. So beyond just validating the causal link, what are the broader implications? I mean, if we have such a perfect mathematical concordance, what does that empower us to do now, clinically speaking?
Well, it empowers us to act with immense confidence, really. This concordance validates the causal link between elevated BP and CVD, no question. And it's a significant strength of the evidence we have. What's more, these treatment benefits, they've been consistently demonstrated across a huge range of baseline blood pressures, from moderately elevated all the way to very high.
Yeah.
And importantly, in individuals both with and without prior established cardiovascular disease.
Yeah.
So it's not just for people who've already had a heart attack or stroke.
Great.
It's a broad, consistent effect across the spectrum, which makes a really strong case for widespread intervention.
Okay, but when we talk about intensive treatment, lowering blood pressure aggressively, listeners might naturally wonder about side effects. It's a common concern. We often hear about dizziness, maybe feeling faint if blood pressure drops too much. How do the sources address these safety concerns? Do the benefits truly outweigh the risks for everybody?
Yeah, that's an important question and a very common concern in clinical practice. The review directly addresses it. It asserts pretty strongly that for the vast majority of patients, the treatment benefits far outweigh any potential risks for adverse effects. And a crucial point highlighted here is something called the nocebo effect in antihypertensive treatment.
The nocebo effect. That sounds like the opposite of a placebo, right? What exactly does that mean in this context? Why is it relevant for blood pressure meds?
It is indeed the opposite. Think of it this way. The nocebo effect is when patients report adverse symptoms, mainly because they expect them to be treatment-related. Even if those symptoms are pretty nonspecific, like fatigue or headache, or they occur at similar rates in the placebo groups, the people not actually getting the active drug.
Uh,
So, double-blind, placebo-controlled trials, where neither the patient nor the researcher knows who's getting the active drug. They're designed specifically to minimize this effect. For instance, the 1993 TOMHS study, Treatment of Mild Hypertension study, was a large RCT. It found overall side effect severity scores were actually significantly more common in the placebo group than in the group getting the real drug treatment.
Hey, really? More common in the placebo group. That's a surprising fact.
Yeah,
So some of what people attribute to the medication might just be negative expectation or just normal background noise of life.
exactly. Or just noticing things more because you're paying attention after starting a new medication. Now, that's not to say real adverse events don't happen. Things like hypotension, low blood pressure, or syncope, which is fainting, or injurious falls, electrolyte imbalances. They can occur with intensive therapy, but the data consistently shows they are infrequent and typically manageable, often just by adjusting dosages. The concept of numbers needed to treat, or NNT, versus numbers needed to harm, NNH, helps illustrate this. In the SPRINT trial, for example, the NNH, the number you'd need to treat to cause one adverse event varied from about 508 for hypotension to over 3,000 for an electrolyte abnormality.
So you'd need to treat hundreds, even thousands of people intensively to see one significant side effect like that.
Precisely. It shows their relative rarity compared to the widespread cardiovascular benefit, where the NNT to prevent a major event is much, much lower.
Okay. And what about this idea of J curves or U curves? You sometimes hear that suggests harm from very low blood pressure, that you can go too low.
Right, another common concern and another viewpoint that needs critical evaluation based on the best evidence. While these J and U curves suggesting risk goes up at both very high and very low levels are frequently seen in observational studies, the review emphasizes they have never actually been reported for randomized comparisons in RCTs. Never.
So the gold standard trials don't show that dipping too low increases risk.
Correct. In fact, RCTs have consistently identified benefits of intensive therapy right across, as the review puts it, every segment of the J or U curve. So the benefits of preventing heart attacks, strokes, heart failure, they continue to outweigh the adverse effects of intensive treatment, even at blood pressure levels previously thought by some to be too low based on those observational curves. The RCT data just doesn't support that lower limit of safety or upper limit of benefit in the same way.
Okay, that's really clear. So given all this compelling evidence from RCTs, this surprising mathematical concordance, how have the official guidelines for diagnosing and treating hypertension actually changed over time? And maybe more importantly, what challenges still remain in getting this robust evidence translated into real-world practice?
Well, the diagnostic criteria have significantly evolved, largely driven by this accumulating RCT evidence. It's been quite a journey. The very first Joint National Committee report, back in 1977, set the diagnostic criterion at a diastolic blood pressure, DBP, of 105 millimeter Hg or higher. Pretty high.
105, wow.
Yeah, by 1993, the JNCV report included an SBP component, setting the threshold at SBP of 140 or higher, or a DBP of 90 or higher. That 14E90 became a standard for a long time.
Right, 420/90, I think many people still think of that as the threshold. So what's the current trend? Have we moved towards even lower numbers based on that mathematical concordance we discussed?
We have, at least in some influential guidelines. The 2017 American College of Cardiology and American Heart Association guideline, the ACCHA guideline, significantly lowered the diagnostic cut point. They lowered it to an SBP of 130 millimeter Hg or higher, or a DBP of 80 millimeter Hg or higher.
130 over 80, okay.
Yeah, and this really reflects that growing body of evidence showing benefits kick in at these lower thresholds. It's moving closer to where the mathematical concordance suggests optimal intervention might lie.
So the U.S. guidelines moved lower based on this powerful evidence, but
Mm.
are all global guidelines aligned on this? That seems like a really critical piece for widespread control for impacting public health globally.
No, they're not. And this is a really persistent challenge, a major hurdle. Many international guidelines, including those from the World Health Organization, European bodies, Japanese, Canadian guidelines, they still recommend SBP 140 or DBP 90 as the diagnostic values. And what's fascinating, and frankly, truly counterintuitive here, is that many of these guidelines paradoxically recommend a lower treatment BP target than their corresponding diagnostic BP level.
Wait, that seems incredibly contradictory. You diagnose at 1490, but then aim to treat below that? How does that make sense?
It is confusing, isn't it? It can create real barriers for clinicians and patients. If you're not diagnosed until 1490, why treat aggressively below that? It creates inconsistency.
So what does this global guideline disagreement mean for actual hypertension control worldwide? Especially when you think about populations in, say, middle and low-income countries.
It means that despite having incredibly strong evidence and effective, often inexpensive treatments, the translation into widespread clinical practice remains, well, suboptimal, to put it mildly. Population surveys show absolutely no global decline in hypertension prevalence overall. It's static or even rising in some areas. And the control rates are frankly shocking. In 2019, worldwide, only about 28% of people with hypertension in high-income countries, and a mere 7.7% in middle and low-income countries, achieved control even to that conservative target of below 490 millimeter Hg.
7.7%. That's a staggering disparity. It suggests a huge number of people are still at preventable risk, even using older, less aggressive targets.
Indeed. It's a massive public health failure, really. And what's crucial to understand, getting back to the math, is the mathematical reasoning behind achieving widespread control. To get a high percentage of a population under control at any given BP level, say 14090, the average blood pressure of the treated population actually has to be considerably lower than that target level. For instance, in big trials like ALL-HAT and SPRINT, even when the average SBP achieved was around 135 millimeters Hg, only about two-thirds, maybe 67% of participants actually got their SBP below 140 millimeter Hg.
Ah, because there's always variation around the average.
Exactly. So this means aiming for an average BP well below the target threshold is absolutely essential if you want broad population control. It mathematically pushes us to consider even lower average targets to really get the majority of the population protected.
So wrapping this up, what does this all mean for you, our listener? The mathematical evidence, which has been meticulously built up over decades of these rigorous randomized controlled trials, it makes a powerful, really undeniable case. Not just for understanding the link between blood pressure and cardiovascular disease, but for acting decisively on it. It feels like a clear pathway to saving lives on a massive scale.
The evidence truly is clear. Lowering blood pressure, even to what might seem like pretty low targets based on older thinking, significantly reduces CVD risk, and importantly, with minimal relevant adverse effects for most people. This robust mathematical concordance, this near-perfect mirroring between the observed risk and the reversal of risk with treatment, it's just such a compelling argument for reevaluating current diagnostic and treatment threshold. Globally, it's really a call for a paradigm shift, one that's grounded in hard, irrefutable data.
Yeah. This deep dive really reveals a striking pattern in the data. The more precisely we measure this, and the more decisively we intervene based on that measurement, the more lives we can save. So, what stands out to you most about how this knowledge could transform global health, especially when you consider those regions still struggling with those incredibly low control rates?
Well, I think it raises a really important question for future research, but maybe even more urgently, for implementation science and health policy. Given this overwhelming mathematical endorsement for more intensive treatment, what novel strategies, what interdisciplinary collaborations are truly needed now to overcome these persistent global challenges in hypertension control? How can we better translate this powerful evidence into widespread clinical practice, into public health policy? How do we ensure these proven benefits actually reach every individual at risk, regardless of, where they happen to live or what specific guidelines their local healthcare system might be following? The mathematical evidence is there. It's incredibly strong. But the real-world application, well, that still has a very long way to go.
A critical challenge indeed, and a crucial question to leave our listeners with. Thank you for joining us on this deep dive. We really hope this exploration has given you a fresh perspective and maybe some truly thought-provoking ideas to mull over about blood pressure and the power of evidence. Until next time, keep digging for knowledge.